Dysmorphic syndromes, a case-based approach. My name is Dr. Carolyn Jones. I am a professor of pediatrics and pathology at Rush University. I actually worked at Loyola for a number of years, and that's why they've asked me to give these lectures. So the objectives include understanding the different inheritance patterns, recognizing and managing options for various syndromes, and identifying common features of Marfan syndrome, Duchenne's muscular dystrophy, Beckwith-Wiedemann syndrome, neurofibromatosis type 1, and Smith-Lemli-Opitz. So inherited disorders are diagnosed in all ages. So we primarily think about them as pediatric age, but they can actually be inherited or diagnosed as adults. So I tried to choose some of those. Again, some are diagnosed during childhood, but many are not diagnosed till adulthood. And diagnosing these disorders is important in both management and anticipatory complications with patients, as well as diagnosing asymptomatic family members. So the way I put this lecture together is I have some questions at the beginning. Without an answer, we're going to go through the scenario and then we're going to have the answer. So a 40-year-old man had a lesion on his abdomen removed. The pathology identified the lesion as a neurofibroma. On physical exam, the patient has 10 cafe-au-lait spots and axillary freckling. What is the most likely diagnosis? Tuberous sclerosis, Noonan syndrome, neurofibromatosis type 1, neurofibromatosis type 2, or Klinefelter syndrome. So our first patient is a 40-year-old man who noticed a few raised lesions on his abdomen and 2 lesions on his leg. He's had numerous brown spots on his trunk and limbs, and he states that he's had these since childhood. Here we have a family history with our patient indicated by this arrow. He has 2 children, 2 sons who are both healthy. He has 2 brothers. One does not have cafe-au-lait spots, and the other has similar brown spots as he does. His father died at 63 from complications of a stroke. He also had a number of these cafe-au-lait spots, and his mother is alive and healthy. On exam, the blood pressure is 130/90. He has 6 fleshy, soft lesions on his abdomen and lower extremities. There are over 20 cafe-au-lait spots identified on the trunk and upper and lower extremities, and he has freckling in the inguinal and axillary regions. So this is actually consistent with the clinical diagnosis of neurofibromatosis type 1. This is a common disorder occurring in about 1 in 3,000 individuals. It's inherited in autosomal dominant fashion. And in order to be given a clinical diagnosis, you need 2 of the following: a family history of NF1, 6 or more cafe-au-lait spots, 2 or more neurofibromas, Lisch nodules, we'll talk about what that is in a second, optic glioma, angiofibromas, or axillary or inguinal freckling. And this patient had 1, 2, 3. So he already, likely 3. So he actually fulfilled clinical diagnosis. Let's talk about cafe-au-lait spots. To be given a clinical diagnosis, you need to have over 6. Post-pubertal, they have to be 1.5 by 1.5, prepubertal 0.5 by 0.5, so you can see 1, 2, 3, 4, 5, 6, and this is just on the back, not even the rest of the body. Usually when I see somebody with possible NF1, if it's an older individual, I usually stop counting when I get to 10. And if I'm still searching for that 6th or 7th cafe-au-lait spot, they probably don't have it. Freckling under the arms or in the inguinal region, these are non-sun exposed areas. 85% of patients will exhibit this feature by age 10. And that's another important thing, how old the patient is that I'm diagnosing. Neurofibromas are soft, fleshy growths, superficial or deep, and they usually start around pre-adolescence. So I don't see these in young children. They usually start around puberty. And here's a pathology picture of spindle-shaped cells with collagen and nerves. Optic glioma is the most common CNS tumor. 15% of patients have this when they're imaged. And 1/3 of patients with a glioma develop decreased visual acuity, proptosis, and proptosis, see this big tumor's kind of pushing this eye out a little bit, strabismus, headaches, obviously, if you have this big thing here, and nausea are other common features. Lish nodules are iris hamartomas, and I've never actually seen lish nodules that look like this. This is somebody with really blue eyes, and you see these brown spots in there. But I have seen this on board, so I swear this is probably in a slide deck of pictures that they use for the board. So if you see this, think of NF1. Again, the age can differ. 25% of patients will have this by age 5, 50% by 10, and 95% by 20. So if somebody's in their 20s and presents to me and do not have Lish nodules, they probably do not have NF1. Whereas if they're 5 or younger, the fact that they don't have Lish nodules doesn't change the differential diagnosis significantly. Orthopedic signs, these are usually in young children, and it can be the first sign. And you can see this abnormality in the limbs. This is a very severe birth defect. Hypertension is very common in patients with NF1. It can develop at any age and is usually essential. Other causes of hypertension include renal artery stenosis and coarctation of the aorta. Genetic testing, NF1 gene is identified in most patients with NF1. Other possible disorders that can look similar to NF1 include Legius syndrome, which is caused by a change in the SPRED1 gene. I doubt that this will be at the level of your boards. Or NF2, which is actually important. There can be neurofibromas, occasional cafe au lait spots, and a risk of acoustic neuromas, and this is caused by the NF2 gene. We're trying to name things better than we used to. Management of neurofibromatosis includes a yearly eye exam. We're not so much worried about Lish nodules as we are optic glioma, because that can cause significant issues. Close monitoring of blood pressure because of the risk of hypertension. Removal of neurofibromas if they're in areas causing irritation, such as a belt line or a bra line. Women with NF1 are at increased risk to develop breast cancer, so breast MRIs are recommended after age 50. So here we have our question again. A 40-year-old male had a lesion on his abdomen removed. It's diagnosed as a neurofibroma. On exam, he has 10 cafe au lait spots and axillary freckling. So now these are two major criteria, plus the neurofibroma. So that makes it more consistent with neurofibromatosis type 1. But this is the only other one that you might think about, but this particular scenario will be more consistent with 1 than 2. So let's talk about our other possible diagnoses here. Tubular sclerosis is characterized by they can have cafe au lait spots, but they, instead of having hyperpigmented lesions, they have hypopigmented lesions that can be seen by a Wood lamp. Kind of this almost like acne or angiofibromas. They can have periungual fibromas, and these can be very painful in either the hands or the feet. Retinal hamartomas, cortical tuber subependymal astrocytomas, seizures because of these cortical tumors, and another early sign of tuberous sclerosis is cardiac rhabdomyomas. They can become very large, and they can actually result in loss of the pregnancy. However, they usually resolve afterwards. It's inherited autosomal dominant, and it's caused by the TSC1 and the TSC2 genes. And then Noonan syndrome. It's common, about 1 in 1,000. Features include short stature, wide-spaced eyes, kind of the shield chest with wide-spaced nipples. But pulmonary stenosis is kind of the, pathognomonic heart defect. They can have multiple cafe au lait spots, but again, they're usually dysmorphic. It's autosomal dominant, and it's caused in most cases by a mutation of the PTPN11 gene, but there are a number of other genes that can result in Noonan syndrome. I would just remember the PTPN11 if you were going to remember anything. And then let's get to NF2. Neurofibromatosis type 2 is caused by the NF2 gene, and clinical characteristics include unilateral bilateral acoustic neuroma. So this is the pathognomonic type of feature of NF2. So NF2, they'd be talking about ringing in the ears or acoustic neuroma. They're also at risk of meningiomas. They can have neurofibromas. So here's just a picture of all the neurofibromas. They can have gliomas, juvenile cataracts, so not pressure on the eyes, but juvenile cataracts. So that's how you would differentiate NF1 to NF2 is acoustic neuromas, meningiomas are more part of NF2. Klinefelter syndrome that was just there. It's a common chromosomal abnormality. I'm going to talk about it more in the other lecture. Tall stature, behavioral problems, and postpubertal small testes. And instead of 46 chromosomes, they have 47. They have 2 copies of the X chromosome. Our next patient is a 22-year-old female who has a father who died of an aortic dissection. There was concern he had Marfan syndrome, and a mutation of the FBN1 gene was identified in postmortem testing of the father. The patient was found to have the same change in the FBN gene as her father. Which of the following tests is recommended? These are the questions that you hate, because it's like you read and you're like, oh, maybe it's Marfan. So then they tell you it's Marfan, and then they ask you what you're supposed to do about it. So renal ultrasound, head CT, audiology, echocardiogram, or pulmonary function test. So a 17-year-old presents for a school physical. She's a pretty good student in school, and she's on the basketball team. She dislocated her shoulder a year ago and continues to have pain. Here we have our family history. The patient is of mixed Caucasian descent. She has 2 brothers, ages 15 and 21, and she's actually taller than both of them. Her mother is 52, and she's 5'2" tall, and her father died at 51 of a sudden death. There was question that he might have had an MI, and he was 6'3". The father had 2 brothers. One died at 35 of an aortic dissection, and he was 6'4", and his other brother is 5'10", and he's alive and healthy. And the paternal grandparents, the paternal grandmother's alive and healthy, and the paternal grandfather died at 52 of sudden death. Nobody exactly knows why. And the mother's an only child. So, on exam, our patient is 170 centimeters, which is greater than the 95th percentile, with a wingspan of 188 centimeters. Her weight is 48 kilos, which is 10th percentile. She has a long face and a high arch palate, which you can't see on this picture. The cardiovascular exam indicates a S1, S2 with an ejection murmur, and the chest wall exhibits a pectus excavatum. There's scoliosis, and the extremities show arachnodactyly or long fingers, increased flexibility, and a positive Steinberg thumb and wrist sign, which I'm going to show you in a few minutes. She also has flat feet. Review of systems indicates she's worn glasses since 3rd grade for myopia. In addition to her shoulder dislocation, she's had a bad ankle sprain a few years ago, and she was diagnosed with scoliosis at age 12, and she has a 20-degree curve. The family history. So in the clinical diagnosis of Marfan syndrome includes family history, skeletal systemic features, cardiovascular, and ocular. So let's go through the systemic features or Gantt criteria. There are actually a point system. So flat feet, you get a point, or pes planus. A Steinberg thumb, if you can do both of these things, you get 3 points. If you can do one or the other, you get 1 point. Additional systemic features include a chest wall deformity. If it sucks in like this, a pectus excavatum is a very common birth defect that you get a point, but if it goes out like this is a pectus carinatum, you get 2 points. And having a scoliosis greater than 20 degrees, you get a point. Spontaneous pneumothorax, 2 points. Spontaneous pneumothorax is another feature of Marfan syndrome. Again, a pneumothorax is a separation of tissue between the lung and the chest wall. If you were stabbed or shot, it's not unusual to have a pneumothorax, but spontaneous is basically you're walking down the street and you have this horrible chest pain, and they find extra air and they have to put a chest tube in. So usually when I'm asking somebody, have you ever had a pneumothorax, they ask what that is. I'll ask if they've ever had a chest tube. If they don't know what that is, I know they've never had one. So additional systemic features is either the lower body is greater than the upper body, or what's easier to measure is the wingspan greater than the height. So I take the length and then I measure the wingspan. Other things include stretch marks, especially up the back. This is really common in a lot of individuals as they're growing. You only get a point for that. Myopia, if I worried about everybody with myopia that had Marfan's, I'd worry about everybody. Mitral valve prolapse, and then facial features, long face, high arch palate, crowding of the teeth. And when I say crowding of the teeth, I'll usually ask if they needed braces, and before they got the braces, did they get teeth removed? Wisdom teeth do not count. Ophthalmologic features, ectopia lentis, or upward dislocation of the lens. In the metabolic lecture, we talk about downward dislocation of the lens with homocystinuria, but upward is associated with Marfan syndrome. Flat cornea, elongated globe, myopia. Cardiovascular features of Marfan syndrome include a dilated aorta, aortic dissection, mitral valve prolapse, which is, these are major criteria. This is just in the systemic features because it's super common. Marfan syndrome is inherited in autosomal dominant fashion, which means you have 2 copies of all of your genes. Just one non-functional copy of this gene can result in features of Marfan syndrome. About 75% of patients with Marfan syndrome have a family history. With 25%, it's something new in that individual. But if there is a family history, or once this individual has Marfan syndrome, there's a 50% chance of passing it on to their offspring, and the complications can be variable. Marfan syndrome is caused by an abnormality of the gene fibrillin, or FBN1, and it's important in giving elasticity to the connective tissue. Mutations of this gene identify a pathogenic change of the FBN1 gene in 97% of patients with Marfan's. And so what that means is if I do genetic testing and they do not have a change in this gene, the risk of Marfan syndrome decreases significantly. So new Ghent criteria, if there's no family history of Marfan syndrome, they either need an enlarged aorta and ectopia lentis, an enlarged aorta or fibrillin mutation, an enlarged aorta or systemic features, so Z-score is how large the aorta is, or ectopia lentis and a fibrillin mutation. So that means if I see somebody that I think might have Marfan's, one of the most important things for me to do is see what their aortic root is, or an echocardiogram. So nobody actually leaves an evaluation with genetics without at least being referred to cardiology for an ultrasound of the heart. When there is family history, so if a parent, in this case, the initial scenario, her father had Marfan syndrome, she only needed one more criteria. Dislocated lens, 7 points on a physical exam, and an aortic root enlargement, a Z-score over 2 for individuals over 20 or over 3 in individuals under 20, a familial fibrillin gene mutation. So again, if your father had Marfan's and you have the same gene mutation, you have Marfan's. So getting back to our patient was found to have a dilated aortic root, and this is just showing the measurement of the aorta. So the patient has 9 systemic features: scoliosis, pectus, wingspan, fat feet, positive Steinbeck thumb and wrist, and myopia, an enlarged aortic root. So our patient meets Ghent criteria and has a probable family history. Marfan syndrome is inherited in autosomal dominant, so there's a 50% chance for an affected individual to pass it on to their children. And as I said earlier, the complications can vary from one family member to another. An identifiable mutation of the FBN1 gene is found in 97% of patients, and DNA analysis can be used to confirm the diagnosis in patients who do not completely fulfill criteria. For instance, when I do this, if I find like 5 points, I usually do genetic testing, even if they don't fulfill criteria. If they have 1 or 2, like they were sent to me because they have a pectus, they have nothing else, I usually don't. I'll get an echo because everyone gets an echo, but I usually don't do genetic testing. So management includes an annual eye exam looking for dislocated lens or severe myopia, close cardiology follow-up, medications used to lower blood pressure, including beta blockers, which can help in the aortic root dilatation, limitation of sports participation if there's an aortic root enlargement, and avoidance of contact sports such as weightlifting and scuba diving, because this can increase your cardiac pressure and increase the risk of aortic dilatation. So our 22-year-old female has a father who died from aortic dissection. There's concern she may have Marfan syndrome. And she has the same mutation, so therefore she does have Marfan syndrome. So what we want to do is know what her aortic root is. Connective tissue disorders that look similar to Marfan syndrome, something called Loeys-Dietz. In addition to looking very similar to Marfan's, it's a lot worse than Marfan's. It can have cerebral, thoracic, or abdominal aortic aneurysms. This is somebody actually I might do a head CT for, which was one of those criteria. Skeletal features include, similar to Marfan's, pectus, scoliosis, joint laxity, long fingers. It can even have a positive Steinberg thumb sign. Things that are a little bit different, bifid uvula or cleft palate. They're at risk of aortic rupture during pregnancy, females are. And mutations of a different gene, TGFBR1 and 2, are found in about 95% of patients with Loeys-Dietz. And then there's Ehlers-Danlos syndrome, characterized by extreme flexibility. They have very doughy skin, and they have recurrent joint dislocations, effusions. This is called the Gorlin sign. They can put their tongue onto their nose. Not that anybody want to do that. They have hyperextensibility at their large joints and extra skin. And they're at risk for mild aortic root dilatation. It's usually not severe. And this is caused by two forms of collagen 5A1 or 5A2. And then Ehlers-Danlos type 4, which they're at risk of aortic dissection, as well as dissection during pregnancy. The two disorders that I actually am most concerned of is not Marfan's as far as connective tissue. It's Loeys-Dietz and EDS type 4. These are much more severe than Marfan syndrome. They can expand, their aortic root can expand very quickly. I know 70-year-olds with Marfan syndrome. I don't know a lot of 70-year-olds with either EDS type 4 or Loeys-Dietz. So let's go on to our next patient, a 5-year-old who's having an increased frequency of toe walking. He has difficulty going upstairs, and his creatinine kinase measured at 22,000, which is the most likely diagnosis. Down syndrome, myotonic dystrophy, Duchenne's muscular dystrophy, or Fragile X syndrome. So a 3-year-old presents to clinic with the following complaints: delayed walking, toe walking, frequent complaints of leg pain, calf hypertrophy, or enlargement of the calf, and an awkward gait. So here's a patient. This is called the Gower sign. I want you to see how this patient kind of stands up going up his legs. The family history of our patient indicates that the patient has a 5-year-old sister who is healthy. The mother's 31, the father's 32 and 33, and there's no other family history of anybody in the family with any kind of muscle problems. The mom has 2 sisters, the dad has 2 brothers. So on exam, there's muscle weakness of the upper and lower extremities, and it's more proximal than distal. There's calf hypertrophy, and so we get a creatinine kinase, and it's 20,000. Normal is like 50. This is consistent with Duchenne's muscular dystrophy, which occurs in about 1 in 5,000 males. It's inherited in X-linked recessive, although I don't like to use the word recessive. We're going to talk about that in a second. The gene is located on the X chromosome, and boys only have 1 X chromosome. Clinical features include progressive muscle weakness, calf hypertrophy, toe walking, and progressive lordosis. Patients are usually wheelchair-bound by age 16, and death in the late teens to early 20s secondary to heart failure or dilated cardiomyopathy. They used to think females had no symptoms of Duchenne's muscular dystrophy because they had 1 good X and 1 bad. However, there's a significant risk as women get older, over their 50s, of developing dilated cardiomyopathy. So this is under the category of dystrophinopathies. Dystrophin is a protein important in the complex that connects actin to the lipid bilayer. And the dystrophin is one of the largest proteins. And every time that the actin and myosin go by each other, it's important to have this stabilization to laminin membrane. The dystrophin gene is the largest human gene with 79 coding regions or exons. And it's located, as I said earlier, on the X chromosome. Small deletions and point mutations can result in a milder form known as Becker's muscular dystrophy. It's the same gene. That's why we changed it to the word dystrophinopathies. They used to name things after people. So what's the real problem in Duchenne's muscular dystrophy? Well, the real problem is when the membrane does not have this structural support. Every time the muscle contracts, because the dystrophin is not stabilizing it to the lamina membrane, there's little openings or like breaks within the membrane. And creatine kinase migrates out. But the other thing is calcium migrates in, which is actually the bigger problem. So elevated CK in the blood is a sign of muscle disease, and it can be seen in a number of different muscle disorders. And it also depletes muscle cell energy. So creatine kinase can be used as energy for the muscle, and so it does make the muscle a little bit weaker, but that's not the real issue. The calcium migrates into the cell, and when the calcium combines to proteases, it becomes active and actually breaks down the muscle, so it's a progressive thing. To be honest, when I see a 2-month-old that's at risk of Duchenne's, their CK might be 20,000. They have no muscle weakness, nothing I could identify in a 2-month-old. It's 20,000. When I see a kid that's, like maybe 5 or 6, it might be 8,000 or 10,000. And when I see a 15-year-old, it might be down to 2,000 because they don't actually have any muscle left. And this loss of muscle, it's taken over by fat cells, and that's what results in the cap hypertrophy. So management includes physical therapy, steroid injections into the muscle to help the inflammatory reaction, which can improve muscle strength, cardiac medications to improve function, and then finally actually dealing with the problem, something called exon skipping, to produce an attenuated dystrophin protein. So 80% of patients with Duchenne's muscular dystrophy have a change or deletion involving exon 51. So we have the DNA, and then we make the RNA, and the RNA makes the protein. So one of the problems is if we make our RNA that has a premature stop codon or deletion, the protein stops at that point. So one of the things you can do is when you're trying to make your RNA, put this PMO charged analog that binds to the mRNA that prevents splicing of the exon. So you make RNA, but you instead of splice 48 to 49, 49 to 50, so on and so forth, you add this PMO that splices 48 to 52. Now, the bad news is you get a smaller protein, maybe closer to Becker's, but you do get a protein, which is better than no protein. So either a deletion or a stop codon results in, again, there's 70-something, exons, and when you're stopping at 51, which means it's too small and it will be eaten apart. Whereas if it's just a couple amino acids smaller, it will, amino acids smaller, it will still be made. So a 5-year-old is having increasing frequency of toe walking. He has difficulty going upstairs. On exam, he has proximal hypotonia. The creatine kinase is measured at 22,000, which is the most likely diagnosis. And the correct answer is Duchenne's muscular dystrophy. We're going to go over this in the chromosome lecture, but briefly, Down syndrome, they have a hypotonia, but they also have other clinical features, including curving the fingers, semi-increased heart defects, duodenal atresia, Hirschsprung's. They have developmental delay. They're at increased risk of autism and Alzheimer's when they get older. Myotonic dystrophy is another muscular dystrophy caused by a mutation. It's actually on the 3' end of the This gene, the myotonic dystrophy gene, there's too many repeats. It results in the gene not being transcribed. The larger the number of the repeats, the more severe the disease. Here are two teenagers. Some of the features include early frontal bossing. They can have cataracts, kind of an expression like a long face, expressionless. The larger the number of repeats, the more severe the disease. Adult onset sometimes first presents with cataracts, and there's a very severe form, a congenital, that can result in myotonia in the newborn period. Fragile X is the most common single gene cause of autism. And I show this picture here because we don't actually look at chromosomes anymore. We actually look at the gene, but they used to think there was a fragile site. Well, there probably is on the bottom of the X chromosome, but this is caused by this gene that's located on the X chromosome having too many CGG repeats that shuts off the gene so it's not functional. Clinical characteristics include large ears, long face, joint hypermobility, low muscle tone, and very large testicles post-pubertal, whereas Klinefelters, if you recall, had small testicles. Okay, our next scenario is a 3-month-old female who has a large tongue, or macroglossia, hemihypertrophy, and a glabellar or red spot on the forehead. Which of the following is the patient at greatest risk for developing? And these are even worse than the last one, because they told you what it was. Now you have to figure out what it is and what they're at risk of. So fracture, anemia, colon cancer, aortic root dilatation, or Wilms tumor. So here we have our patient who's a 3-month-old that presents to clinic. She's at the 95th percentile for height and weight. Her parents are concerned because her tongue is always protruding out of her mouth. So she was born full term by C-section, birth weight of 9 pounds and 2 ounces, and she was in the NICU for 2 days because of hypoglycemia. She was the first child conceived by IVF, or in vitro fertilization. Her mother has 2 brothers and 1 sister. Her father is an only child, and both grandparents are both alive and healthy. On exam, the weight is at the 95th percentile, the length is at the 95th percentile, the head circumference is at the 50th percentile, and here's this glabellar hemangioma, this red spot over the forehead, a protruding tongue. The right ear measures 4 centimeters and the left measures 5 centimeters, and there's creases in the anterior of both ears. Cardiac exam is normal. The abdomen is without masses, but there's an umbilical hernia. Extremities without deformities, normal tone, normal reflexes. The right foot measures 10 centimeters, and the left foot measures 12 centimeters. There's a 1 centimeter leg length discrepancy, with the left leg being longer than the right. So there's what we call hemihypertrophy. One side is bigger than the other. So we have neonatal hypoglycemia, macrosomia, asymmetria or hemihypertrophy, macroglossia, umbilical hernia. And this is Beckwith-Wiedemann syndrome. Beckwith-Wiedemann syndrome is characterized by increased birth weight, hypoglycemia, glabellar hemangioma, hypocalcemia. An umbilical hernia, and a really big umbilical hernia, is an omphalocele. Anterior ear creases, so here's these anterior ear creases. Beckwith-Wiedemann syndrome. Here's some characteristics of Beckwith-Wiedemann syndrome. Here's this baby with a really big tongue. They're at risk of 2 types of tumors, Wilms tumor and hepatoblastoma. Wilms tumor occurs in about 5% of babies with Beckwith-Wiedemann syndrome. Hepatoblastoma, there's a risk of it, but it's much lower. Omphalocele, they can have enlarged organs, and this is very significant hemihypertrophy. Usually it's much more subtle than that. Beckwith-Wiedemann syndrome is caused by an abnormality in the regulation of growth. And this is kind of complicated, but there's a couple genes here, and I want to go over them. KCNQ1 and ICF2, or IGF2. Normally, in the mother, the KCN is only active in the father. So it's active in the father, and it's methylated in the mother. And the IGF is methylated in the father and on in the mother. And this is like a growth regulation thing. If there's too much KCNQ2, because both mom and dad's is active, that can cause overgrowth. If there's too much methylation, the control of the growth, if they're both shut off, then there's no control of growth, and that can also cause Beckwith-Wiedemann syndrome. So one of the things is both copies could come from dad, and if both of these copies of the gene that have the KCNQ on and the IGF off, that can cause Beckwith-Wiedemann syndrome, or if there is a mutation of this other gene that controls this one. And all of these can result in overgrowth. So Beckwith-Wiedemann syndrome occurs in about 1 in 15,000 live births. There's an increased risk of infants conceived by IVF because of abnormalities in methylation. Beckwith-Wiedemann syndrome is associated with increased risk of kidney tumors known as Wilms tumor. About 5% of babies with Beckwith-Wiedemann syndrome will develop a Wilms tumor. There's an increased risk of hepatoblastoma, which is a much more severe tumor, but fortunately less common even in the Beckwith-Wiedemann population. So anticipatory guidance when you make this diagnosis is to monitor for a Wilms tumor. Again, 5% of patients with Beckwith-Wiedemann will develop Wilms tumor. You want to do a renal ultrasound every 3 months until age 8. And to look for hepatoblastoma, which is a fetal tumor, AFP, alpha fetoprotein level, every 3 months till age 3. So a 2-month-old has macroglossia, hemihypertrophy, glabellar hemangioma. Which of the following are they at greatest risk for? And the answer is a Wilms tumor. Patient E. A 6-month-old presents with failure to thrive. The head's height, weight, and head circumference are all below the 5th percentile. He was born full term with a birth weight of 4 pounds and 5 ounces. He had hypospadias at birth and a VSD, or heart defect, in the ventricles. On exam, he has 2-3 syndactyly of the toes bilaterally, and he's noted to have an elevation of 7-dihydrocholesterol. What is the most likely diagnosis? Fetal alcohol syndrome, Prader-Willi syndrome, Smith-Lemli-Opitz syndrome, or Pompei's disease. So we're going to talk about Smith-Lemli-Opitz syndrome, and this is inherited in autosomal recessive fashion, which means both parents have to give a non-functional copy of the gene. It's caused by a mutation of the DHCR7 gene located on chromosome 11. But the important thing to know about this gene, actually, is that it converts 7-dihydrocholesterol to cholesterol. And cholesterol, while being too much cholesterol is bad, not having enough cholesterol is also bad. Cholesterol is very important in the cell membrane. As a result, the cell membrane doesn't function correctly. Clinical features of Smith-Lemli-Opitz syndrome include microcephaly, a short nasal anteverted nose, so you can see this kind of short nose with anteverted nares, ptosis, low-set ears, and when we look at low-set ears, we look for the inner and outer canthal distance, and these ears are a little bit lower than they should be. 2-3 syndactyly, primarily of the toes. This is a really common birth defect, but it can be a sign of this. They can also have polydactyly. Here's an extra digit. Hypospadias in males with a small labia, and females are ambiguous genitalia. So a male that, XY male that seems to have, severe hypospadias or ambiguous genitalia. Congenital heart defects can be seen, including ASD, VSD, and an AV canal. So management is NG feeding of an infant because they often have failure to thrive, and cholesterol supplements. Their cholesterol is actually very, very low. So a 6-month-old presents with failure to thrive. His height, weight, and head circumference are all below the 5th percentile. He's born full term with a birth weight of 4 pounds 5 ounces, which is actually pretty small for a full-term baby. He has hypospadias at birth, and on exam he has 2-3 syndactyly of the toes, and has elevated 7-dihydrocholesterol. Again, they're actually giving you the answer 3 times here, so you pick Smith-Lemli-Opitz. I want to now talk about some other causes of failure to thrive. Fetal alcohol syndrome. failure to thrive is common, occurs about 5%. Failure to thrive with height, weight, and head circumference below the 5th percentile. Prenatal alcohol exposure is important for renal alcohol syndrome. And clinical characteristics include a small head or microcephaly, low birth weight, which results in failure to thrive, long, smooth philtrum, thin upper lip, hearing loss, and congenital heart defects. So we have these shortened palpebral fissures that result in wide-spaced eyes. Again, we've also seen that in Smith-Lemli-Opitz, but one of the distinguishing features is the long philtrum with a thin upper lip. So diagnosis of fetal alcohol syndrome includes fetal alcohol exposure, dysmorphic features, growth deficiency, and cognitive delays. This is one of the most common causes of mental retardation, occurring 1 in 1,000 live births. 1 in 100 babies born have fetal alcohol effects, which means they have some features of fetal alcohol syndrome, but not all enough to make criteria. Prader-Willi syndrome can result in severe hypotonia in the newborn period with failure to thrive, but usually it's postnatal. So they usually have a normal birth weight and length, head circumference, but then it kind of drops off. And it drops off because they have such an inability, their low muscle tone results in them not being able to take enough feeding. As they get older, however, they're at risk of obesity, hypotonia, small hands and feet, upslanting palpebral fissures, and they have cognitive delays. So again, in infancy, they have severe hypotonia, but as they get older, they have obesity. Only the paternal copy of the SNP gene located on chromosome 15 is usually active. So there's 2 ways to get Prader-Willi. 70% of patients have only 1 copy. This tells us it's chromosome 15, and here's a critical region, the 15q11. There's a deletion here. You don't see this red dot. So there's either a deletion of the gene, the SNP gene, located on 15q11. That occurs in about 70% of patients, and this is usually paternal because only the father's copy of this gene is active. And then another 30% result in, if there's maternal non-disjunction of chromosome 15, if mom donates 2 copies of 15 and dad donates 1, only dad's copy's on. But trisomy 15 is incompatible with life. So the cell says to itself, one of you guys has to hit the road. So if it kicks this copy out, you got a copy from dad that's on, a copy from mom that's off, 2 copies of 15, you're good to go. If this copy gets kicked out, you got a copy of dad that's on, copy of mom that's off, 2 copies, yay. But if dad's only contribution is kicked out, then you do have 2 copies of 15, which is compatible with life, but both are turned off at this region. So if you actually think about it, in Prader-Willi, 1/3 of the cases result in a conception that started at trisomy 15, but only 1/3 of these conceptions end up with Prader-Willi. So this event probably happens far more commonly than we know. The next is Pompe's disease, which I reviewed, will review in the lysosomal storage, but it's a lysosomal glycogen storage disease. It's autosomal recessive, caused by a change in the GAA gene. Both copies are non-functioning. Features include congenital low muscle tone. There is an adult form, cardiomyopathy, respiratory insufficiency, and the CK can be very elevated. And again, this is a sign of muscle disease. And again, adult onset can occur a little bit later. So let's go over some USMLE questions. A 12-year-old boy has a particular genetic disease. His mother is a carrier of a mutated gene, but his father is noted is not clinically affected and is not a carrier. The patient has 4 siblings, a sister and a brother who are not affected and not carriers, a sister who is a carrier but not affected, and a brother who is clinically affected. The inheritance pattern is consistent with which of the following diseases? So you have something seen in boys but not girls, but girls can be carriers. So that would tell you X-linked. Alpha-1 antitrypsin is autosomal recessive, CF is autosomal recessive, PKU is autosomal recessive, and Tay-Sachs is autosomal recessive. So the only one of these is X-linked is Duchenne's. And again, I took this out of one of those USMLE testing books. It doesn't talk about the disease or any of the features. It just is. A 25-year-old man presents with hearing loss. An MRI reveals bilateral tumors in the cerebral pontine angle. Surgery is performed and it's removed. Both are found to be neurolomomes or schwannomas. Which of the following is the most likely diagnosis? So this patient has bilateral schwannomas. And this is neurofibromatosis type 2. Schwannomas are on the 8th nerve. Another name for them is bilateral acoustic neuromas. So that's the pathognomonic features of NF2. So, understanding the presentation of common genetic disorders will help anticipate problems such as cancer with Beckwith-Wiedemann syndrome, aortic dissection with Marfan's. Diagnosis of an increasing number of genetic disorders may help early treatment, for instance, enzyme replacement for better outcome. And when reading a question, pay attention to unusual information, an unusual lab, family history information, maybe ethnic background. We'll talk about metabolic diseases and unusual smell of the urine. Underline those things or just take a mental note of them. I know you have this online, so you can't really underline anything, but really look at those questions. Every single word in a question has meaning, so look at what they're saying. And that concludes this lecture.